it becomes clear to us that we need a strategic plan, a
Mhm.
tangible plan that has parts and components in it that everyone can see all of these attempts that we're doing when it comes, if it's increasing Medicaid eligibility, if it's offering Medicaid to undocumented individuals, if it's the public option, all of these different things that we're talking about are fundamentally leading to one central component or one central thing. And that's ensuring that people have the opportunity to attain their best health. If they live in our state lines, we want to make sure that they're one of and among the healthiest people that they can be in our state. Now, fundamentally, our viewpoint on this is that what has impacted us and limited our ability to really get there to date has been our historical connection to structural and institutional racism. And I'm going to call that out specifically because I appreciate, and I'm going to take the liberty of calling the comptroller Kevin, even though I don't know that we're there, but but when Kevin was speaking about how it's going to take more than just to fix insurance, it's going to talk about, it takes
Right.
talking about and looking at and examining safe communities. This is where
Mhm.
people are starting to think siloed and not really going into the broader root causes of why things are challenging for people to get to their health, to get the health care they need and to get to their best health. So from our
Mhm.
perspective, we're unapologetic in trying to call into our conversation, into our discourse, the historical context of difference that we have then put privilege into how we looked at that difference and now have disadvantage. And when we look at that from the context of health, people who are disadvantaged in our healthcare system by design, by how it's designed. And so the
Mhm.
disadvantage by design and by how it's
And how
designed.
it's designed.
So
Intention
specifically,
and impact.
exactly. So
Mhm.
specifically, we're looking at ways to uplift and really talk about acknowledging the role that racism has played in that system, but then tying that to tangible proposals that we can move forward, including, and I know I'm going to talk more about this later, how we make access to health, how we make healthcare more accessible and affordable, meaningful, and located in the places people live, work, play, and grow, and how we
Mhm.
break down the systems that prevent that. We're also looking at ways to address barriers, those social factors that are before us that some of us believe are norms and just how the world is, but in
Mhm.
fact, it is creating barriers for others to access their health. And then
Mhm.
finally, as I've already said, intentionally embedding equity in the decisions that we're making.
So thank you for that wonderful explanation. And it makes me want to hear about how you see community being part of the change process, right? Because when we're at the legislature, and all of us have been there, it's like an alternate reality. Even the best intended, best meaning legislators are caught up in this system, this process that happens. And without the voice of people, it is really difficult sometimes to make the right decisions and choices. So, say a little more, Tekisha, about how you are engaging community in this change work.
So I'm going to answer that in two ways. I'm going to get to the how we do it, but I'm going to start with some principles at the beginning. And what
Mhm.
I appreciate, when Mendi opened, she talked about how the pandemic laid bare the inequities that exist. The other
Mhm.
side of the pandemic, though unfortunate, but it's offered us the opportunity to do things like this, be on Zoom in community together, to talk about issues, to show up in support of issues that we care about from our living rooms, homes, cars, wherever we are. Now, we still have to recognize the privilege that we have to have broadband internet access that's stable, even though sometimes that unstable connection comes up, or or to even have computers and understand how to work Zoom. There's still a privilege that's there. But what's been remarkable about how the kind of being wherever you are and being able to participate has given us is the opportunity for people, everyday people, to lift their voices both in response to what's happening in the pandemic, but what's happening right now at the legislature. So while I am I am ready for the ability to be back together and to be able to have lunches with people and to be able to see people in person. I'm most amazed by how people who are most closely located to these issues are now able to lift their voice. And from our perspective, that's really, really important. We just believe that people who are closely located to the problems, they know their own solutions. They know what they need. They can voice those if they have the opportunity. So what we do at Health Equity Solutions is we don't build a policy agenda anymore. So we've been doing this for the last 3 years. So since 3 years ago, we don't build a policy agenda anymore without reaching out to the people and really deeply engaging in conversations with community-based organizations who are serving people, with the people who are receiving those benefits or receiving those services. And also we talk to policymakers and others to form and craft a health equity agenda that we put forward from a policy and legislative level. It's important to me that our organization goes through this transformation on a rapid basis. We started as this kind of not even a think tank. And I think it's really important to understand we were never meant to be a think tank, but we started as this kind of expert group of people who can do analysis. And even though I have personal lived experience with health and equity from a family and personal perspective, I'm far removed from that in some ways. There are some ways it still shows up. But now we're trying to move from that to being this community informed organization who's also now trying to move from being community informed to community driven. And what that means is that the community is driving the work and the action of this organization and directing us into where we need to go. And I'm really excited about that and hope that we have opportunities to do that more, not just as an organization, but as a state, that we find a way to really engage and hear from and do it in a meaningful way, the community.
That is really exciting, really exciting. And I'm gonna flip over to talking about some of the legislative initiatives that the two of you are working on this year, and ask Kevin to give our audience a high-level overview of Senate Bill 842, and address in the course of doing that, the importance and what you hear from outside, what you hear from everyday people. How is it community informed? I know it's not community driven, but.
And I just want to point out that when Francis says a high level interview, that's a sort of a clue that I need to like keep it tight, like keep this tight.
Oh no, you know how technical that bill can be.
It can, and I'm not going to try to go into all the intricacies
That's
of
right.
it. So Senate Bill 842 has, the shorthand for this bill has been called the Public Options Bill. And it gets at uninsured status and access to healthcare in a couple of different ways. And the first, and I'll talk, it's not my area of expertise, and Francis may have more to add about this, is really like, what does the individual do, right? Someone who doesn't have access to employer-sponsored coverage, who's in the individual market, who goes to Access Health CT, the Obamacare, the Affordable Care, the Affordable Exchange, to buy care, like what is their experience? What can they afford? How much subsidy is there available? And tries to ratchet up those subsidy and do away with subsidy for people in a certain band of the federal poverty level, and try to provide additional support for people in the band just above them, and raise the threshold on Medicaid so that we can get folks who, just miss it, right? To have access to a healthcare program that will allow them to continue to do what they need to do to take care of their families and live in their community. The part I'm more closely associated with is the small group side of it. And that's really an attempt to leverage the work that I already do with the state employee and retiree healthcare plan for the state, with about 260,000 lives, to make a difference for small businesses between 1 and 50 employees, for nonprofit organizations of any size, and for the Taft-Hartley plans, which are union health plans that may choose to come into coalition with us for purposes of buying insurance. The small group piece probably needs a huge explanation, but it really is aimed at a segment of the market where employers have walked away from health insurance because they just can't afford the premiums any longer. And as a result, their employees are put in a very precarious and difficult position. So when you look at the number of people in that market, that's how it's defined as a market, that number has been shrinking. And the number of providers, the number of insurers who are in that space has been shrinking as well. So it's really starting to form what we call a death spiral, meaning that fewer and fewer people hang on to coverage, fewer and fewer insurers are interested in doing business with them. And then you end up with a sicker population that remains because they know that their claims will likely outpace the premiums that they're paying.
And if I can interrupt you for a moment, I just want to add a point of emphasis that during 2020 and the loss of employment from those kinds of small businesses that have had to lay people off or even shut down, so many of those employees have been left without insurance at all, if they had it, right? And the ability to get affordable coverage. Yeah, that's an important face of the moment.
Delicate link between employment and healthcare, right? The fact that that's tied so intimately is, in some ways, was a great development for the society when it occurred, but now becomes this strange thing when people need healthcare the most, like during COVID, and then they lose their employment and lose their health insurance simultaneously. The second group is those nonprofit organizations, and I'll just say one thing about that. There are not-for-profit organizations in the state of Connecticut that are doing the work of the state of Connecticut, meaning if they weren't doing their work, the state would have to pick that up. So they're largely on grant funds from the state. Some of them are operating in the healthcare space. And a whole bunch of them can't afford to give health insurance to their employees.
Right.
So like if you back up a second and think about the injustice there, right? So these are taxpayer dollars funding vulnerable populations through these nonprofit organizations, yet the employees who are actually doing the work don't have access to healthcare. That has to be like a full stop for us, for a state. Like we cannot allow that to continue. But this isn't something we dreamt up at the Capitol, right? This is based on feedback and information that's coming out of the communities, out of small businesses, out of nonprofits that are struggling and want to do the right thing by their employees, but just can't find an affordable option. And sometimes the affordable option is a high deductible plan, which means sometimes there's $6,000 in deductible standing between you and healthcare, or 15 or more. So that's not meaningful. It's just not meaningful. That's not to Tekisha's point, like we want to be the healthiest state in the country, or we want to have like
in a real way.
Yeah, in a real way, and not just because we can put it on a banner, but real.
Yeah. Well, Tekisha, before I turn to you and ask you to talk about the bills that you're tracking, I want to invite our audience to start putting their questions in the Q&A, because I'd like to be able to pick some questions and go back and forth and have this be a virtual conversation to the extent that it can. So Tekisha, I know you're doing a lot of work on racism as a public health crisis. Tell us about that and some of the other bills that you're working on.
Sure. I'll start by just acknowledging from a kind of a real response way, I guess, real time response. We are a nonprofit small business, and we attempt to very much mirror the employer we are asking the world to be. So we pay 100% of the premiums for our staff. And it is very, very difficult to do that, maintain and keep up with the market competitively around salaries, and to kind of keep and hold employees. So we're really, from an employer perspective, very excited about the opportunity to look for ways where healthcare can be more affordable, and just bringing that to kind of a real crystallized point. As the advocates that we are, we know that affordability for healthcare goes along a huge spectrum, from people who can't afford it individually, who don't have access through their employer, but also people who don't have access at all based on their documentation status, which we know is rooted in antiquated, xenophobic policy structures that don't allow from an easy perspective to become a citizen in our country. So one of the things that we definitely support from a legislative perspective is expanding Husky availability to individuals who are undocumented residents in Connecticut. We also pair that with wanting to expand or restore eligibility to Husky to 201% for parents. And I know that I think in the next in the next webinar series, there's going to be a deeper and richer conversation about that. So I'm not going to go really, really deep into that one. I'm going to pivot and talk about Senate Bill number 1, which was just heard last night in the Public Health Committee, because it includes this declaration around the state around racism as a public health crisis, but it also includes a number of our other important policy solutions that came from our listening sessions. So we have been doing work around this in a municipal level. 20 cities and towns and the Mashantucket Pequot Tribal Nation have declared racism a public health crisis in the state of Connecticut. And we believe that's an important first step in understanding what the context of the historical and contemporary context that racism has connected to health, but it also gives us the opportunity and the pathway forward to begin to deal with these issues. Within the Senate Bill 1, there's an opportunity to bring forth a committee to actually examine racial disparities in public health and put forth ideas on how to eradicate those and eliminate them. We also find in Senate Bill 1 an opportunity to require hospitals to change their community benefit structure. And we think that's really important because we think that hospitals, just like everyone else, have a responsibility, specifically nonprofit hospitals, just like everyone else, have a responsibility in their communities to pair their community health assessment work and their community health plan work with how they're actually spending their community benefit dollars. So we think that those three things should align, and all of that should align towards health equity. And then I think finally what I'll note is we are huge proponents of changing the imbalance in maternal mortality that is impacting Black women at striking rates in the United States, and even specifically here in Connecticut. And one strategy to doing that is ensuring that they have the advocates necessary in their life and in their birthing process to make sure that they have great outcomes. And so we've been supporting the reimbursement of doulas, and the Doulas for CT is an organization led by doulas of color particularly, but they're specifically, it's a diverse group, but we've been supporting them and what their efforts are in providing resources to making that happen. So that's just a flavor of what's all in Senate Bill 1 and what we're interested in, what we're up to.
And I think the fact that it's really all in partnership, right? That everybody is moving or spearheading something, and what we're doing is really being shoulder to shoulder on these bills. I think that's happening with the public options bill. It's definitely happening with expansion of Medicaid to more people at 201%. It's happening with the immigrant health bill, and certainly with SB 1. And if we don't, it takes a village. It definitely does take a village, and a strong one at that. I actually, I want to go back to Kevin. There's two questions that I have, right? And one is about, they're both related to equity. And I'd like to understand from your perspective, Kevin, you really have oversight of the state employee health plan, as you noted at the outset, and you are, you negotiate with hospital systems. So Tekisha is talking about the community benefits and the needs assessment, which we've known for a long time now, since the ACA passed, that although it's a federal requirement that the needs assessments be conducted every 3 years, I think it is, that there's a disconnect between the community benefits component. And so you're negotiating on prices and with the hospitals and with the insurers. How are you using your levers, the levers of your office, and are you seeing an impact on equity out of the state employee health plan?
Not yet, to be frank. Not
Mhm.
yet. I'd like to say yes. I could probably give you a flowery little thing that sounds like yes, but I don't think
Mhm.
so.
No.
Because when I look at what my first charge is around those direct negotiations, it's really
Mhm.
about quality and cost. Because the back end of this argument is that if we can't get sort of quality first and cost rationalized, then we'll never be able to develop a system that actually, funds access to healthcare for folks as the price of that continues on a fee-for-service basis to just be out of reach. So like, do we do work inside the plan around access, around mental health access, around access to different choices for women who are going to give birth around where they want to have their baby and under what circumstances? Yes. But
Does the
I'm not
state
at the
employee plan pay for doulas?
You're not going to be surprised to know that I just texted and asked that question. I think the answer is probably no. I'm on it though, Tekisha. I'm on it.
Thank you.
You're in trouble.
Well, yeah,
You've got
because like
Tekisha and me.
in many ways, like this is a short little sort of aside, and I'll stop talking. But like I come to this job as an advocate, like as an unlikely comptroller, right? I wasn't somebody who like climbed through the political ranks to get to this job. I'm someone who came from public health and came from AIDS
Right,
work, and
right.
like understand what really can happen on a
You know
community
that,
level.
yeah.
When I
Mhm.
think about the AIDS pandemic, and I think about the moment where Black women, and in this case, white gay men, sort of came together to really do something and get the New York Times to say that our people were dying. Like, what are we going to do? Like, that was the moment. And I live for that moment again. It's what
Yeah.
drives me to do this work every day. So we've leveraged our plan for a whole lot of things that are just and are right. But right now, I'm trying to move a healthcare system through our negotiations from turn the turnstile fee for service, you get paid more for you doing more, to like, what does the whole episode of care look like? And who does it really well? And where would I send my mom for a hip replacement, and where wouldn't I? And how do I feature those hospitals and those providers as the ones that everyone should have access to? But then again, I'm also a guy that thinks that, Medicaid should be, taking folks with Medicaid coverage should be a condition of licensure if you want to be a medical provider in the state. So my views on this might be a little sort of, off the
I
edge.
think we would endorse that.
Thank you.
Well, there's a question, there are a couple of questions in the Q&A, and I think that they're relevant to SB 842. And I'm going to take one of these questions, and then we can come back a little bit to talk about the role of data collection and analysis, because that I think is really at the heart of a lot of why we don't know the answer to how well we're doing on policy implementation. So what are the biggest barriers to making progress on bills like SB 842 and the health equity agenda? And this question is for both of you. And what can people like our audience member who's not identified, like me, do to help break open the gridlock and see change?
Keisha, do you want to go?
That's an awesome question. So I'll start by saying I think some of the biggest barriers around advancing the health equity agenda in Connecticut, I'll call it. I've been playing around with the wording of this. I'll call it the inconvenience or the convenience of how we are structured in this state. With 169 cities and towns that are very segregated, both along the lines of race and wealth, it is very easy to not know that there are geographic, racial, gender disparities that exist because they're not happening in your backyard. So the biggest barrier is getting individuals to understand that while statistics show we rank in the top 5 as one of the healthiest states in the nation, those same reports rank us as number 41 in health disparities, meaning we're at the bottom of the list of having some of the most disparate differences between people on the healthcare side. So it's this kind of, what's the story of Connecticut? we're rich, we're wealthy, we are progressive, all of these things we say about ourselves, and yet there are people who are living every day here who are not able to get the healthcare that they need. Calling that out and making that really clear to people that we can't rest on these kind of inconvenient truths or convenient truths that we have about who we are and the story we tell, and really getting to the heart of what we need. The second piece that's connected to that is getting people to get the data. But and I don't want to jump too far into the next question you have, but you kind of lifted it up for me. But we don't have good data collection in this state that across all of our health agencies, or to people or places that touch health, and across all of that information in a shared way to really get a clear picture. And I'll just give you one quick example, and then I'll answer the part about what can you do. When we started getting COVID-19 data, and I'll be really, really quick about this, early on, and it's just how public health data works. We were getting one or two reports, and I'll make something up. We had a death from this novel coronavirus, and the person was a 53-year-old white man from Fairfield. So we would get those details. But as it started growing and growing and growing, if you would remember, we were getting fewer and fewer information about race and ethnicity. We would probably get, and even gender, we would get all of this information. So we had to call that out and really ask, hey, where is this race and ethnic data? Because we need to know, are there disproportionate impacts happening on populations? And lo and behold, you'll find if you start looking at the vaccine data, DPH is reporting it and saying we can't keep reporting it because we're not sure that this information is good enough, right enough. There's poor collection. We don't have enough information to make meaningful understanding of it. That's a problem. We frankly need to be able to tell the story of what's happening in our state for every single person who lives here. And some of the best data, to Kevin's credit, exists in our state employees because there's a different mechanism of how we're collecting that data, but we need to do a lot better. Those are the two biggest barriers. And I think those are things that people like us who are having this conversation together can take the mantle up and really argue for.
And it's, it's the collection of data on a standardized and consistent basis. And then it's the use of that data to analyze it, to then be able to use it to evaluate policies, to evaluate outcomes, to make interventions that are necessary. And I think I agree with you, Tekisha, that the state employee health plan sort of has a captive audience in its membership, right? And so it does have pretty robust data collection, and still you're not necessarily collecting by race and ethnicity and language. There's so Kevin, would you like to take the question about the biggest barriers to making progress on Senate Bill 842?
Yes, but no one's going to be surprised by the answer, right? So we are sometimes called the insurance capital of the world. Right? Yeah. So that presents some real difficulties. And even with our staunchest allies in this fight, when hundreds of employees of insurance company X flood your inbox with form letters that were frankly written and generated by their employer for them to send, it's intimidating. It's, and it tells one side of a story, and it's always about what, this horrible thing is going to happen if you say enough. We need to change sort of how this is going. I don't know that we have the luxury to just step back and not do anything. So the lobbying effort is tremendous. And I know we've entered in the last 4, 5, 6 years into this truth is relative thing, but the lack of real data driving real decisions and truth, what's truth and what's not truth, is when you start to say, wait a minute, here's the data, here's the actuarial report, here's the numbers. And they're like, oh yeah, but my nephew said this. Oh, these aren't the same thing, right? We have to, the peer-reviewed studies and this actual data has to be held at a higher level of recognition than what some knucklehead said at a party. We can't sort of make our decisions that way. So it's scary. It's scary for legislators. It's scary when insurance companies come in and say, you know, we're going to have to rethink our commitment to Connecticut if you do this. It really, you know, is unnerving. But this has to be a conversation about more than how many insurance jobs do we have?
Right,
How many
right.
do we used to have? How many are we going to have? And think more broadly. I mean, the companies I contract with, Anthem Blue Cross and Blue Shield, Connecticut, Signify down in Fairfield, in Stanford, they're growing because of their contracts with us. And we're using, you know, their skills for good, and helping us to understand what's hidden in these systems. Together with the innovation this unlocks, if we're able to get this right, you know, the big box employers are easy to stabilize an employee base, right? To say, okay, we've got these big chunks, and we get nervous when they make noise, but that's not where the growth is. That's the shrinking part, actually. And they've been sloughing off folks forever. The 1, 2 to 50, that's the growth. Those are the folks with
Right.
real roots in this state. When Connecticut is named the 4th most innovative state in the country, and historically, we sprinkle economic development money around with winners and losers instead of saying, how do we take our assets and our smarts and all of that
Correct.
stuff and make a difference in the balance sheet of anybody who wants to step out of that cubicle and is too afraid because they've got a young family or a pre-existing condition and they can't lose access to their benefit. We're strangling
Totally.
ourselves.
Totally. We're missing the boat. And there's a question about, there are 2 questions in the chat that are kind of relevant to this issue. What would expanded access to quality, affordable healthcare do to help our economy? And how would these healthcare reforms impact our ability as a state to attract small business startups and the employees for Connecticut's future economy? I've been, you know, sort of saying a lot lately, our economic recovery as a state depends on having healthcare taken care of. We need to deal with our healthcare problem, our affordability and access problem, because it will drive the economic recovery. I also have been, you know, really watching and trying to understand, where do people of color fit there, right? So there are small businesses in this state owned by people of color, and there are people of color in this state who want to make that jump that you're talking about, just like there are people who are white that want to do it. But their barriers to entry are significantly higher. Healthcare is a huge one. So I'm, you know, interested in both your thoughts about, like, if we really got a good plan, for, you know, offered by the state of Connecticut, that people like, you know, any of us know friends, family members who want to go out on their own and start a business or have a business and they want to expand it, they want to grow it. What would that happen? What would that do to our economic recovery?
I'm going
And
to
to
be very
equity?
brief. I'm going to be very brief, and then turn
Question
it to
was very
Kevin.
long.
No, but I think Kevin has more of the background and the experience to answer this question. I'm going to do it from a personal experience. I run a small business, and if I did not have to worry about healthcare, we'd be twice the size we are now, probably even 3 times the size.
I hear you.
And so that means there would be, and I'm one example, right? But that alone is somewhere between 10 to 20 more jobs, 10 to 20 more people employed here if I didn't have to worry about healthcare. But because I have to worry about healthcare, there's this delicate balance of controlling what the world looks like. How can I get the work done with a smaller staff? Because every person I hire, there's all of these things that come into it, the expensiveness of it, the smallness of the market, the age rating, all of these different pieces kind of come all into that. And so we're not going to be discriminatory at all, period. So I have to think literally for every person I hire, how much is this going to cost me? And that's actually the driving factor, not their salary. It literally is, how
It's
much
the
is the healthcare
package.
going to cost me?
Yeah, I co-signed to that, being the president of a small nonprofit organization as well. Yeah. So Kevin, what do you say about the economy and equity?
So I think the table is set, right? The opportunity is there if we want to offer it, right? So we can say as much as we want, we are pro-business, no wrong door, Connecticut's open for business. That's all fine. But so much still of access and information is tied to the old, I'm going to call it the old boys network for lack of a better description. But like who knows somebody who knows somebody, and who like can get you information, and how I'm going to say it because maybe Tekisha won't, but like who's going to know that we're going to change the ages around COVID vaccine before everybody else knows, so we can get in line, right? If you don't know that person, well, think about how that breaks out by who we are based on race and based on gender and based on ability and all of those things. So, you're right. I mean, there are lots of micro businesses, small businesses. I used to take our youngest son to have his hair braided in New Haven, and there were like 6 women from the African continent there, braiding hair. And like and this was a business, and they needed healthcare. And we would talk at length about sort of what that would mean if it was affordable, predictable, and it was a meaningful benefit, right? We don't want people paying for junk. So if you have the state negotiating price, we can drive down the cost. It's not free, and it's going to be borne by the people who sign up for it. It's going to be no impact on the taxpayer, but it won't have all of that non-value stuff built into it. Because if we're going to assign a value proposition to every piece of the healthcare delivery system, it's going to be first on the patient, next on the provider, next on the hospital. When you get to like insurance executives, they're going to be very low in the priority list. And I'm sorry to say it, but we only have $1. What are we going to do with it?
And when you have the people at the center of the decision making and the policy making, the choices become much clearer. I have a question. First of all, I'd like to ask Mendi. Mendi, if you'd like to jump in here, do you have any question that you'd like to ask of Tekisha or Kevin?
Thank you. Thank you so much, Frances. I'm just actually currently eating it up. I just think this is such a wealth of knowledge, but I will jump in if something occurs to me. But
Okay. Well, feel free, definitely. I wanted to say that I wanted to ask about the municipal resolutions, right? Because a lot of the change needs to be at the mind and heart level, both mind and heart level. And we are living in a time when we're thinking very austerity mindset, and that if someone else has something, and a lot of the criticisms that you hear around a public option is that the taxpayer is going to have to pay, and I'm going to have to pay for those people. And it's like, right. So what does it mean for a municipality to declare racism a public health crisis at a practical level? What are they being asked to actually do? And I want to go as far as to ask, have any municipalities in Fairfield County declared racism a public health crisis?
You're gonna make me pull up my map, and hopefully I can remember in my head. So from the perspective of what does it do for a municipality, municipalities have the control over zoning laws and all of the different things that work at the very local level that control our everyday life. And so making the recognition at a local level that racism is a public health crisis gives you the opportunity to do what New Haven has already done. Created a task force, started going step by step and thinking, what are the things that we can change within our ability to make a difference around eradicating or dismantling the relationship between racism and our citizens in New Haven. The work that's being done there is amazing, and they took this on themselves. And I just have to say, the most exciting part about this movement in Connecticut is that it is being done by the people. it is local individuals. We put the research together. We put together the outline of what you can do for a resolution or a declaration. We've paired the experts, stuff that has come from other states, and said, and here's what's next. But it's more so like we're giving resources and getting out of it, and the people are taking it over. So this is giving us the opportunity to think about when people say, I don't want more affordable housing in my backyard. That's not the answer here. It's starting to really evaluate. So really, what are you saying? You don't want those people. Who are those people? And how is that disadvantaging the individuals who live in your backyard right now, but can't afford housing and are struggling paycheck to paycheck to make a way? I'm getting a little preachy, so let me back up and say the next piece. I don't remember off the top of my head that any of no, there's a technicality. Bridgeport at the town level, at the city council level, actually did pass the declaration, but the mayor has to sign declarations for them to go into effect in Bridgeport, and he did not sign. So we can't add Bridgeport to that list. I know Stamford had a consideration, but I can't remember exactly where that went. And I'd have to kind of pull up the list and see if there are other cities and towns, but it's also on our website.
I just thought our audience might be interested in knowing. And I think what you've just described as kind of the people basically taking it up, and what we've been talking about, like the policy at the state level, and really pushing the policy making and the people together in a more effective way and driving it. So there's a question in the chat that says, what can we do to help advance these great policies? I am going to put that out to you both, and you can flip a coin as to who goes first.
Not it. You got it,
Kevin. Well, I think the answer is probably going to be similar, right? So there's the legislative advocacy piece, which is almost the easier answer. And then the other is like, well, what else needs to be happening? Like, how do we advocate locally in our communities to make sure that this conversation is happening from top to bottom and not just ethereal, at the state capitol? And I'll say that, I hope we're getting to the point where we understand that we can't just rely on people of color or legislators of color to carry the weight of these issues at the Capitol, at town and city halls. Like, we all need to be committed to this if we're really going to be who we say we are, or who we believe we are. And if not, so on the narrow question of Senate Bill 842, it is all about contacting your legislator. And I know Representative Kristen McCarthy-Vahey was on the call. I don't know if she's still here, but a major champion for many, many good things. And I always count on her energy and her work to get things done. But we need, 150 more of her. And the way we get that is to try to put in the calls, put in the emails, and make the contacts. And particularly if you're a small business owner, or you're a person with an idea that could be a small business, but you feel held back, or you're a nonprofit administrator or executive, and you're struggling here as well, because sometimes it feels like the story that's the counter story that's being told is that we're a solution in search of a problem. Like somehow this is not a problem, nothing to see here, just keep moving.
Yeah. Don't boil the ocean. I heard
don't boil the ocean.
A major hospital leader say one day in a public
You want to see
forum.
boil the ocean? We know how to boil the ocean. This isn't it, right? This is an incremental change. And I'll just say one thing quick on zoning. I was thinking as you were talking, Tekisha, about like what the municipalities are doing. When we moved to the town we're living in from New York City, I was put on the Planning and Zoning Commission as an alternate. And one day a letter came in from a neighboring town that said, if you want to connect to our sewer system on the west end of town, we can work out an arrangement for you to do this. I got all excited. I'm thinking, okay, high density housing, we could do more mixed use, and they were like, slow your roll. Like, we like our 1, 2, 3 acre zoning. We like the septic because I'm like, I don't quite, I get it, but we're at a time where we can't get away. We shouldn't be allowed to get away with that. So call, and call the governor as well. This is not just about legislators, because if we're successful in getting this done, it's going to land on the governor's desk. And the governor said he was for the public option, and it's a little quiet right now, and that makes me nervous. So we got to remind him what he said he was for, and what we're for, and why it matters.
Tekisha, you wanna address 842 if you'd like to, as well as the other bills.
Yeah, I'm just going to say on a principle level, just broadly, the question about what can we do to advance these things, I would say, educate yourself on what you don't know. This is an opportunity just like tonight. Live curiously and be brave in that curiosity to know and understand what it is you've not engaged with before, or you've heard about it, or even if you see a commercial, don't fall prey to the message. Kind of figure out what is the truth there and find your own truth there. The other piece that I would say is start by being very uncomfortable with the status quo. We have to break ourselves free of this land of steady habits business and realize that the status quo is reinforcing, but we are reinforcing the structures that are creating disadvantage and continually disadvantaging people if we're happy with being comfortable. And we have to get uncomfortable. We have to push our limits and think a little bit differently. And I loved the question about what will this do for our economy, because it's really like, I didn't have an answer till you said it. I stopped and thought about it. This is what it is. If we want to be fiscal, if we want fiscal to be fiscally responsible, we have to eliminate poor interventions that are not working because we're not using our data to do the right things, right? So we just need to be led by that. And so learn what you don't know, use your voice, be brave in doing it, and be prepared to be uncomfortable and be okay with that. And be okay with that. That's going to push us forward. And specifically, you can find all the information on our website for the bills. I should say that, because there's all the detail about all of the bills that we talked about.
Yes, and you can also go to Universal Healthcare Foundation's website and learn about all these bills as well. So there is no lack of opportunity to become informed. That is certain. And to be informed and to act on that knowledge. And there are mechanisms, there are, ways that you can align yourself to different coalitions. And you mentioned allyship. And I want to go back there in terms of allyship and the importance of it. And we're all in this together, right? Some of us as a society, as a community, are worse off, a lot worse off than others by virtue of economics, geography, race, ethnicity, language, legal status, gender identity, all the distinguishing differences. But we are in it together. And, someone very wise said to me not too long ago that we really, in Connecticut, need to understand that we can be an allyship across geography and race because we're all dealing with the same issue. And housing in Fairfield County is just such a good example. Everybody, well, not everybody, but a lot of people struggle to afford housing. I have a friend who is in very high administrative government in Greenwich, who says that most of the people who work for the town of Greenwich can't afford to live in the town of Greenwich, right? That is an inequity that is exacerbated by race and ethnicity. That's the, right? So allyship to make this, what I'm trying to say is to make it possible to find common ground. We're terribly divided as a country for a lot of reasons, and we're not immune to that here in Connecticut. And healthcare is an opportunity to come together, right? Across race, the people in high-income communities in Fairfield County and the people in low-income communities in New Haven need healthcare. Our needs are the same. We're all human. And so we really do need to work together and to be uncomfortable in that allyship, but to do it. Because the people are ahead of the leaders in a lot of ways. that's my experience in the years that I've been doing this work. The people are ahead of the leaders, and the people need to take the leaders where they need to go. So any closing remarks before we say goodnight to everyone? I don't have any more questions in the Q&A, but it's been really wonderful to see you both virtually and to have this conversation with you. And Mendi, thank you so much for your partnership at the Community Foundation, and to Steve Saloom, whose name shows up on the screen, and all his good work, and Erica Stanley's work there as well. Thank you.
This was terrific. Thank you both. As Frances said, we really appreciate you taking the time this evening. And I think you've given us some excellent grounding to move forward with. So thank you.
All right.
Pleasure.
Well, everyone, all the best. See you next time.
Thank
Bye.
you.